Welcome to the Yenna Club of Cardiac Surgery Enthusiasts.
We are a group of young cardiac enthusiasts exploring the world of heart surgery from every angle.
From the lecture hall to the simulation lab
to the doctor's office, where we dive deep into patients' care.
We're here to share the realities, challenges and thrills of cardiac surgery.
We will talk about groundbreaking research and innovation in cardiac medicine. And yes, sometimes we will bring you the lighter side of surgery too.
Get ready for stories, insights and interviews from the heart of the city of science, Vienna, Germany.
We are cardiac surgery enthusiasts and this is our podcast. Enjoy the episode. Welcome to the next episode of our podcast. Today's guest is originally from Chile and has become one of the most influential figures in the field of cardiac surgery. He has dedicated his career to advancing the care of children with congenital heart disease and currently serves as a chief of cardiac surgery at Boston Children's Hospital and William E. Ladd Professor of Child Surgery at Harvard Medical School. He is widely known for developing a cardioplegia solution that has transformed myocardial protection and is now used around the world in both pediatric and adult cardiac surgery. With over 500 scientific publications, more than 50 patents, and a career marked by innovation, leadership, and mentorship, he continues to shape the future of cardiac surgery. His name is Pedro del Nido. Professor del Nido, it's a great honor to have you on our podcast.
Thank you. It's a pleasure to be here.
You were born in Santiago, Chile. Can you tell me about your early years and what brought you to the United States?
Well, I grew up in Chile. I lived there until I was 10 years old. My mother, who was a veterinarian and a researcher, found a position in the United States. And so we moved to the central portion of the United States, to Wisconsin, where I grew up. I went to college. I went to medical school there. And that's where my career started.
And why exactly medicine? Did you have any other options or thoughts?
Medicine? Oh, well, my father was a surgeon, and his father was a physician. And so I think in my family, there was no other choice. I was very interested in engineering. I was interested in biochemistry. And in my undergraduate studies, I studied quite a bit of biochemistry and engineering, but eventually went into medical school to continue my work there.
And why exactly pediatric cardiac surgery?
Well, that decision, I had no specific interest when I first started medicine. I knew I wanted to do surgery because I liked working with my hands. I liked the sort of immediate gratification of fixing something and seeing the results right away. And that just sort of fit my personality. But it wasn't really until I actually specialized in cardiac. I liked cardiac right from the beginning because I liked the physiology. I liked the challenge. In those days, cardiac was still early in its development. But then I rotated in my part of my residency training. I rotated through I did my residency in Toronto at University of Toronto, and we rotated through the Hospital for Sick Children in Toronto, and that for me was a transformational experience. In that I saw something very challenging. I saw things that were amazing to me. And I decided that this is something that was really appealed and I wanted to do it.
And who were your most influential mentors, so to say, during your training in Toronto or in Pittsburgh and Boston?
Well, one has many mentors as you go through your career. I think in my early stages, when I was a resident, when I was a general surgery resident, my mentor was actually a Brazilian surgeon who was my chief resident, and he was the one who really encouraged me to pursue cardiac. He went and became a very well known cardiac surgery, Randas Batista, and but then in Toronto, it was Tyrone David who was my probably strongest mentor and still is to this day. As my career advanced in Pittsburgh, for example, it was Richard Simmons, who is a very famous general surgeon who actually wrote the textbook on surgical infections. He was the chief there, and he was the one who really encouraged me to pursue an academic career, the idea of doing research, systematic research to advance the field. That what he was well known for that, and then and had a huge influence in my thinking about what I wanted to do.
Thank you for that answer. Let's talk a little bit about Tyron David because I'm really curious about him. My mentor, Professor Dunst, he also worked with him for a year at Toronto, and he's telling me always great stories, inspirational stories about him. I'm really I admire him a lot. Could you please tell me some untold story or from the OR or outside of it?
Well, what always impressed me and really stimulated me was he combined both the dedication to technical proficiency, his technical ability and technical excellence, with also the concept of looking at your results and analyzing your results and constantly trying to improve. In other words, being very objective about how good you are really doing and figuring out how you can do better. And I think in my view, there are very few people. I've met many, many surgeons who are technically superb. I've met many, many surgeons who are extremely brilliant scientists, but individuals who combine both, I think that's unique. And that's what Tyrone is.
What is your opinion about combining science and intraoperative skills? I mean, what is the key? Because you're an example of someone who mastered both. What is the key?
You have to dedicate yourself specifically to both things. There's no shortcuts. There really isn't. And that's what I learned from Tyrone. Tyrone would look at what I was doing and give me sometimes brutal criticism of my skills or lack of skills. And it forced me to think about, okay, no, there's a more precise way of doing this. There's a better way to do it. There's a way to save moves. There's a way to be less traumatic, and sort of kept increasing the standard for you. And I also met individuals who did the same thing for me on the science side. That said, no, you can publish a paper, but the quality can be improved, and you can go into a much more selective journal, and you can publish something that now has quoted by everyone or cited by everyone. So they always kept rising the standard for you, and that's good. I mean it's challenging, but it forces you to think about, okay, how can I do it better? How can I improve what I'm doing? Not just be happy and say, "Oh yeah, I've got this and I'm great." Pat yourself in the back, but you're not really improving.
Do you still remember your first operation as a senior surgeon or as a resident?
Well, as a resident, I don't remember too many. I mean, it was a blur because it was so busy in Toronto. We were, in every service that we rotated. I do remember the first operation I scrubbed in with Tyrone. I had been in the laboratory. All I had ever done in for cardiac or heart procedures, because I had done general surgery before, was in animal experiments, in dog experiments. And I show up to the operating room to work with this individual who I barely met, and spent my time just trying to stay out of his way. He was so fast, so precise, and just knew exactly what he was doing, and I was just slowing him down. And he was getting very impatient with me, and I had no idea what was going on. And I'll never forget that. And at the end of it all, he says to me, "Well, Pedro, I'm not sure you can be a cardiac surgeon," which to me was devastating. I thought, "Oh no, no!" If this great person says that to me, but he came back and he said, take that as a challenge. Don't take it as a criticism. Take it as a challenge. You need to get to this place. You're down here, but you need to get to here. And that's the way to think about it.
And looking back, what's the one thing you wish you had known when you were just starting out in cardiac surgery?
I don't have any real regrets. I mean, my career path followed my opportunities. I didn't have a preset plan, or I'm going to do X, Y, Z, and at this time I'm going to do this time. No, I looked at my opportunities that I had at the time, and I made the best of it. For example, when I finished my training, my fellowship in congenital, there were no jobs available anywhere. My only potential offer was a position in Winnipeg, Manitoba, which is way up in the north of Canada. But I had an opportunity to go to University of Illinois to restart a program that had been shut down. So I had to start from scratch, and mostly doing adults. And I just took it because the senior surgeon there, the chief of the program, was someone I respected very much. Was a well-known investigator. And I thought, hey, this is an opportunity, and it was the best thing I ever did. It was a huge, important, significant experience for me, because I started a program from scratch. I had to learn how to do everything, and it gave me a background that I would never have obtained. So you make the best of your opportunities and you work with it. So I followed that career path always. There's an opportunity there that looks like it gives me a chance to grow, a chance to learn. Go for it.
When we talk about opportunities, how important is it to create them? I mean, I'm not a fan of waiting for opportunities. I'm always searching to create them, and I believe that skill is a really valuable skill for a cardiac surgeon.
Yeah, I'm not sure you create opportunities, but more you recognize an opportunity. It's like looking at a diamond in the rough. It's a piece of stone, but if you know what can happen to it, if you work at it and you make it shiny, then that's how you jump for it. But you have to be able to recognize that, hey, this is an opportunity. I can make the best of it. I can make this work, and have enough self-confidence to say, okay, I'm going to go for it and take the risk. The only thing I ever regret in my life is having not jumped on opportunities that presented to me, and I look back and, oh, I should have done that. That is something you will always regret. You never regret jumping into something and it doesn't work. That's fine. You learn. You learn, you go on, and then you keep moving.
And when we talk about opportunities, research, and technology, what clinical problem were you trying to solve when you first developed the Nido cardioplegia solution?
Well, the I didn't set out to develop a cardioplegia solution. It was totally serendipity. When I went to Toronto, I had been accepted to the residency program. When I get there, they said, well, we had to give your position away to someone else, because their job got turned down. So we offered them an extra year. So we're going to send you to the lab. So I said, okay, I go to the lab. I'd never worked in a laboratory. I mean, I had done as an undergraduate, I'd taken courses, but nothing official. But at the time, the big topic was myocardial preservation. There were many, many studies that were being done to try to improve, and the results were not very good. The St. Thomas solution was the main one at the time, and that was developed in experiments in rats. And what relevance it had to adults or humans, very we didn't understand. So I just went into that area, but I was fortunate in that I went to the Banting Institute, where I was surrounded by scientists who really, really knew their field, and that stimulated me to say, okay, there's much more technical detail here that needs to be investigated, and that's how I got started. My first job out in Illinois was working for a mentor who, that's what he had been known for his cardioplegia, Sidney Levitsky. So it gave me the opportunity to continue that work. But it was the understanding that, we had to really limit the period of time that we could fix the hearts, because we knew that if you went beyond 45 minutes, 60 minutes, the likelihood of the heart coming back was very poor. And so in order to do more complex procedures, we had to somehow figure a way to extend it. And that was the challenge. It wasn't really until I got to Pittsburgh that it really began to kick together, and you begin to understand, okay, these are 3-4 different strategies, all have to be put together into a single solution. And then I was able to test it in a way that really was required before going to humans.
Yes. And did you face any early, so to say, skepticism or resistance from the surgical or perfusion community when introducing the solution?
I think the biggest skepticism that I faced was the idea that you don't need to give, at least for this solution, you don't need to give every 15 minutes, another dose of cardioplegia. People were very, very nervous about that. They said, "Oh, you're gonna damage the heart. You have to keep giving it." And I said, it's not as if the solution is somehow a nutrient that you have to keep feeding the heart. The solution, all it is just water that's cold, and and all you're doing is just keeping the heart cold. You're not, if it's beating again, you're stopping it. But really, there's no rationale for it, except for maintaining the temperature and keeping the heart stopped. That was a very difficult concept for people to really accept, and it wasn't until people saw, and it really started with, here in Boston, residents rotating from other hospitals would come and they say, "Well, why aren't you giving cardioplegia every 15 minutes?" And I said, "Because you don't need to. And, if you do this right, keep the heart cold, not beating, you don't have to." And so that's how the word got out, and it was spread by word of mouth. And that people said, "Oh yeah, well, that makes the process of the surgery a lot simpler, because I don't have to stop everything in the middle of something critical and give cardioplegia and then start again." And it seemed like that's how people got convinced.
And the solution contains mannitol as an osmotic agent. Was its inclusion primarily to reduce the myocardial edema, or were you targeting free radical scavenging as well?
No, we had looked at free radical scavenging, but it was primarily for myocardial edema. That was the main. That was the main. We tested a number of different ingredients. Mannitol, the impact of mannitol was, I would say, minor. It wasn't huge, but it definitely had a beneficial impact, and so we kept it in. It's certainly not harmful, and it's easy. It's cheap. Our goal is to try to make something that everybody could use and everybody could make in their own hospital. You didn't need a commercial laboratory to make it, because that way you could be in Southeast Asia, you could be in Africa, you could be in India and make it yourself. And so we were trying to use simple ingredients that you can get almost anywhere, and make your own solution, and that was part of the goal here.
Yes. And why did you choose lidocaine as a sodium channel blocker instead of alternatives like procaine or quinidine? Is there any difference, by the way? Or
Yeah, so we knew we wanted to block the sodium channels because we knew that that was a major mechanism by which sodium and calcium got in and damaged the cell. So we tested a number of things. At the time, procaine was the ingredient in St. Thomas solution that was most popular. The problem was that it's is very short acting, and so we needed something that was going to be a long term blocker, and so that's why we tested lidocaine, and we found that the lidocaine is what gives you the prolonged arrest and gives you the prolonged blockage, and it isn't until you really wash it out that you really begin to see the effects of the lidocaine go away. So I wanted something that would give us at least an hour, maybe even longer, of complete arrest, and the lidocaine was the agent. I'm sure there are other sodium channel blockers that you can use, but again, we were looking for something that everybody has, and lidocaine. Every hospital in the world has lidocaine. It's as simple as that. So that was part of the reason too.
and what criteria did you use to decide the concentration of magnesium in the final solution?
Yeah. Yeah, that's a good question. So magnesium, as you know, is a divalent cation, and so it's a competitive inhibitor of calcium.
Yes.
And so we knew we wanted to have high concentrations in order to prevent the calcium binding inside the cell. And we knew that a lot of the calcium transporters would take magnesium in, so we experimented with various levels. What we found is the levels that were used in some of the early experiments, which are very high levels, 16 millimolar, had other effects. They activated platelets. They had other inflammatory effects. And so we little by little we began experimenting, ratcheting it down. We found that 4 millimolar was equally effective, but didn't have a lot of the other side effects. And so that's how we came up with that concentration. So it was just a lot of iterative experimentation that got us to that point.
And in terms of buffering capacity, why did you choose sodium bicarbonate over histidine? For example, histidine-based buffers, which are used in other cardioplegic solutions.
That was in fact originally we did use histidine. That was our original. Again, the problem was obtaining histidine was very difficult. Now, histidine is a perfect buffer because its PK is exactly where you want it, 7.1. And so that's where it works most effectively. And it's the most ubiquitous amino acid. So we knew we needed buffering because we wanted to get the protons out. Bicarbonate is helpful. The problem with it is very volatile. And so you have to put it in almost at the time that you're going to use it. But what we found is the best buffer is red blood cells. So red blood cells have carbonic anhydrase, and all you need is a very small concentration of red blood cells, and they'll buffer just as well. So that's how we settled on it. But I agree, histidine is a very, very good buffer. It's just, again, if you're in an average hospital, you're not going to be able to get histidine to make a solution. It's just not. It's not readily available.
And what evidence supported the use of 1:4 blue to crystalloid ratio? And have you experimented with adjusting this ratio, for example, in high risk or adult cases?
So that work we did very early on, because once we decided that we wanted to use the red cells as a buffer rather than oxygenated red blood cells that are going to provide oxygen, then that changed. What all we needed was a small amount of buffering, because at cold temperatures the amount of proton production is very low. And all we wanted to do was buffer enough of the protons so that we could keep anaerobic glycolysis going. So you don't need very much, and that's how we started with various concentrations, very dilute, even 3% hematocrit, all the way to full. Above 7 or 10%, you don't see any benefit for the buffering capacity. And so we said, well, if we're trying to use as little blood as possible, let's settle on a number that's below 10%. And that's how we came up with a 7. Much more dilute than that, you lose the effect.
And let's slowly migrate to innovation. You are owner of more than 50 patents. And was a typical path from idea to patent to prototype in your innovation process?
Well, I had to learn that. No one teaches you.
Yeah.
No one teaches you that in medical school. But the one thing that I learned I learned it with the cardioplegia is that we patented the cardioplegia. But the reason why we patented it is because, well, the university said, well, if you patent and you are awarded the patent, you can put it on your CV and it looks very good on your CV. And I said, okay, great. So we submitted it, we got a patent for it. The university said, congratulations, and that was the end of that. And so, of course, anybody can make it. But what I learned was that if you then want to try to develop it as a product, you have to go beyond just the patents. You have to demonstrate the patent. All it allows you to do is to protect a certain knowledge, a certain method, or a certain approach that you invented. But it doesn't tell you whether it's going to work or not. Okay, and so what you have to do then is develop the next level of prototype that will demonstrate that, yeah, your concept really works. Okay, and that's the next step, is proof of concept. Then if you're going to scale it up, proof of concept is great for your lab or maybe 2 or 3 labs. But if you're going to scale it up so that thousands of these devices or this treatment can be made, then you have a different problem, which is, okay, how do you manufacture this device in a way that you can make thousands and thousands and they're all equally good? The quality is there and so forth. That's a commercial effort. And so that's a very different level of something. Again, we don't learn in medical school, but the engineers and people in the commercial world know that the proof of concept, which is important, doesn't always translate into something that can be made thousands and thousands of times and always the same quality. And so that's a specialty. That is something then gets taken, and then you try to see if in fact it's something that can go and other people use as a commercial venture.
And can you tell me about the inspiration behind your patent for a geometrically accommodating pediatric heart valve?
Yeah, so that was again a challenge that we were facing because of the problem with tetralogy. That is a huge challenge. Tetralogy of Fallot is the second, third most common congenital heart defect. Everybody thinks, well, you close the hole, you get rid of the obstruction, the problem is solved. No, that's just the beginning. These kids have problems with pulmonary regurgitation lifelong. And what we found is that we were having kids that were having 2, 3, 4 operations to keep putting in new valves as they were growing. And so we said, okay, what else can we do? Can we design a valve that will grow with them? And I had initially done some work with tissue engineering. The idea was, to me, it was very attractive. The idea, okay, you take the patient's cells, you grow them in a scaffold, and they will grow with the patient. But I saw that people hit a wall. They could get the cells to grow, but to become a true valve that then continued to grow and had the structure of a valve with different kinds of cells, different layers, that was hugely challenging. And so what we decided to do is just take a totally different approach. We just said, okay, forget about biology. Let's look at mechanics. If I had to design a valve that goes from one size to this size, how are we going to do it? And then we realized that a venous valve does that all the time.
Yes.
If the venous valve in your leg, when you're flat, very small, you stand up, water column this high, it gets bigger, but it still works. It's still a valve. So we analyzed the geometry of that valve and spent a lot of time looking at the relationships of the leaflets. And we said, okay, let's just exactly mimic a venous valve with materials that we know are biocompatible. And so we chose EPTFE because people have been using that for valves for decades. And that's how we came up with the idea. And then worked with some very smart engineers who helped us design the stent to hold it, and ways to manufacture it. And then we had the proof of concept, which is what led to the publication. We were able to make the device, put it in animals, show that you can not only have it worked well in animals, but you can balloon expand it to different sizes, and it still continues to work as the animals grew. And so that was our proof of concept. To take it from there to the humans was a whole different level of development, and that required a professional organization, a company that does that. In order for them, because there are requirements by the regulators, FDA, and so forth that have to be met. But now it's I think we have almost 40 children now with those valves in place as part of a pivotal trial for FDA, and I think if we're lucky, by the end of this year, we will have completed that trial, and my hope is that it'll be approved for use everywhere.
And I'm curious about what does triggers the expansion of that valve. I mean, are there biomaterials or what are the triggers?
It's purely mechanics. It's a balloon expansion.
Okay.
So you implant the valve at whatever size the child is appropriate for that child. And once they outgrow it, then you go in with a balloon catheter, expand it to a larger size. And the design of the stent is that it'll expand but still maintain the geometry of the valve, the circular geometry. And the leaflets are very tall, but as the valve expands, the leaflets come down, but still coapt. And that's it. It's an ingenious design made by Mother Nature. It took 1.5 billion years to develop, but we're not making it any better. We're just copying it.
I believe that the mother nature is the best inspiration for technologies.
Yeah.
And let's talk about surgery. It's our passion, innovation as well. But my I'm curious about in cases of onychospid aortic valve in childs. Have you developed reproducible repair strategy, or do you favor early Ross procedure?
No, we've done both, but I still favor reconstruction. I think in the early years, the Ross is a beautiful operation. It's a beautiful concept, and you're putting in a valve that will grow with the child. It's their own valve. But the problems of the right side are real. Those children will outgrow whatever you put in there. I think it's very different if you're doing a Ross in a 12-year-old, 15-year-old. You put in something adult size, and on the right side, they can have transcatheter procedures, and there are better solutions. Young children, I would do reconstruction, and I think we're our results, they're not long term, but we've developed ways to reconstruct these valves, whether it's bicuspidization, whether it's Ozaki with single leaflets, whether there's a number of ways that you can reconstruct unicommissural aortic valves in children that can preserve much of their valve tissue and avoid the a replacement until they get older. It's not a long-term solution. This is just to get them to an age where there are many other options, and replacement with a Ross is certainly one of them.
Yes. And what's your approach to supravalvular aortic stenosis with associated valve dysfunction? Do you address the root and valve simultaneously?
Yeah, so one of the things that we've learned, and this is where we believe that having engineering teams embedded in the clinical program is absolutely necessary. So the geometry, as Schaefer's has taught us, the geometry of the aortic valve is very precise. The relationship of the annulus to the sinotubular junction, the geometric height, all of that, very precise. So what you try to do is to try to replicate that geometry. So the idea is if you know the annulus diameter and if you know the geometric height, you should know exactly how big to make the sinotubular junction in order to have a valve that's competent. And so you base your plan of reconstruction on the geometry that's required for that valve to work well. And there we have, in our place, you have engineers that come, we've already made a 3D model from the CT scan, and we know precisely how many millimeters we want to make the sinotubular junction, the free edge length, the geometric height, all of that information is available, and that's exactly what we do. And that's what's given us pretty good results. And I think that's the way to approach it. To eyeball it and say, "Oh, it looks good," that's not reproducible. That's just not reproducible.
How often do you use 3D printers and 3D mapping for planning complex surgical cases? Or do you do that for every case?
Pretty much. Oh, yeah. Yeah. Particularly for congenital. Not 3D printing. I think we stopped doing 3D printing long, long ago because it's just too cumbersome. It doesn't add anything. If you have a visual on a computer of the three-dimensional structure and you can rotate it around, you can cut through it, you can analyze it, that's all you need. And so we do that with every complex case that we do. We obtain an MRI or a CT and reconstruct a 3D model, including valves. Now we're doing mitral valves, tricuspid valves, and as I said before, the aortic valve. That's our standard. I believe that in the future, that's how we're going to do all of these reconstructive cases.
So we spoke about your mentors, but now you are a mentor. So could you please tell me what are the skills in residence that you are searching for?
I think the most important thing for the mentor is, well, two things. One is to be the role model, okay? Because your trainees want to mimic whoever they aspire to be, and that was my view of individuals like Tyrone David, like my other mentors. You have to be a role model, and that means that you have to walk the walk and talk the talk. You have to not only say the right things, but you have to do them. The other is to devote the time. We're all extremely busy. Everybody has a million things going on, but to make the meeting with the individual a priority, that's the key. And so you have to have both things. It's not helpful to have a mentor who is a perfect individual but doesn't have the time for you. That's nice, but it's not helpful. And to have an individual who will sit down with you and be your psychiatrist, okay, that's good too, but it doesn't necessarily show you where you need to go. So you need both. You need both things.
And what about the mentees? Is there a big difference between the residents in your generation and the residents now? Because I believe that back in the days, in your generation, there was a big hunger for development, for innovation. Is today like that as well?
Human beings are human beings. They're the same, 30 years ago as they are today. There are individuals who have a hunger for being, a leader in their field, and it doesn't matter whatever field they love and they choose. And then there are individuals who say, I just want a job, I want to make some money, I want to have a good time. And that's fine. I I mean, that's not criticism, but you choose that. Okay, you choose what you want to be. Don't complain though if you don't get the recognition simply because you would rather be sitting on the beach or sitting on your boat and not really doing work in your field. At the other extreme is don't complain that you don't have a lot of free time because you took on so many projects. That's what you chose, and if that's what makes you happy, then just do it. I think mentees, people are people, and there are individuals who choose a certain pathway and the other individuals who choose a different pathway. That's their choice. But in those that really want to make a difference in their field, and those really want to move the needle in their field, there's not that many of those individuals. And to me, those are the ones that I prefer to work with because I know that I can have an impact. And that's who if I'm going to devote some time to the individual, it has to be somebody like that.
And it's my last question. How do you see the surgeon of the future? How he or she should look like? Which skills will be even more important for the future?
I think cardiac surgery in particular needs to continue to evolve. Um, we have seen what's happened to the field over the last 20, 30 years. It's completely different. When I trained doing an internal mammary to the LAD, that was a big operation. And today it's a non-existent operation. Why? Because they go to the cath lab and they get the procedure stented. So the field changes. We as surgeons should be in that development. The story I like to tell is the first balloon dilation of an LAD was done in an operating room by an individual who was actually a radiologist and a cardiologist, but a surgeon showed him where the coronary was. He put the balloon in and expanded it, and it was successful. And the surgeon said, "Well, that's great, but it'll never take off. It's not like surgery." That was the dumbest thing that they could have done. They had an opportunity to own that field. They totally missed it. And so the rest is history. We can't let that happen. I mean, cardiac surgeons need to be in development of novel therapies. And I think if I had to be judgmental, I would say that's our fault. Our fault that we're not the ones doing the TAVRs, that we're not the ones doing the coronary angioplasty because we're very comfortable doing what we do. I think the cardiac surgeon of the future needs to be someone that continues to look at the problem and say, I think we can do better. Let's work on it. And they innovate.
So innovation is the key.
Always, in everything. There's always problems, but individuals who sit down and try to work out solutions, they're the ones who really move the needle, not the ones who just, iterate the same solutions over and over and over again and make it slightly better. That's okay, but it's not gonna make an impact in the field.
So I believe that our talk will inspire a lot of young cardiac surgeons, a lot of students and residents and people all over the world. Dr. Del Nido, I highly appreciate your time, and it was a big honor and pleasure to me to speak with you today.
Oh, the pleasure is mine. Thank you very much for the opportunity.
Thank you very much. Take care. Bye-bye.
Bye-bye.